Thank you, Bijoy, for the invitation. This will be a lecture on neuroimaging in ACTA2 mutation. ACTA2 mutation has a distinctive cerebrovascular phenotype and also a distinctive clinical phenotype characterized by ductus arteriosus, congenital mydriasis, and variable presentation of pulmonary hypertension that can also be fatal. Basically, when you have the combination of this typical cerebrovascular phenotype in this clinical context, the diagnosis is almost sure. The neurovascular phenotype in ACTA2 is characterized by symmetrical arterization, dilatation of the aortic arch and of the proximal carotid arteries, and then there is a transition between dilatation and stenosis at the level of the transition between the cavernous and the terminal segment of the ICAs. And this is important for the pathogenesis, as we will see in a second. The distal arteries assume, as you can see in these two MRA images, an abnormally straight course, almost as if stretched. So why we have this transition from dilatation to occlusion and straightening? Actually, the occlusive arterial disease is observed in the smaller arteries and is probably due to smooth muscle cell proliferation, while the elastin, which is present and abundant in the large arteries, may inhibit the smooth muscle cell proliferation, resulting in arterial dilatation. And actually, you can see that the change from dilatation to stenosis occurs in fact around the cavernous ICA when the external elastic lamina disappears histologically. And here you can see how thickened are the arteries in ACTA2 mutation in comparison to controls. What about the brain? We studied 2 years ago 14 subjects with ACTA2 mutation, and we figured out that apart from the expected findings, so the straightening of the arteries that you saw before, and the long-standing associated ischemic damage in the brain, we also had unexpected brain finding. Hypoplasia and bending of the anterior corpus callosum was seen, associated with abnormal radial gyration in the frontal lobe. And this deficient anterior cingulate gyrus, which you will really not expect in patients with normal developed corpus callosum embryologically. We also have these twin mountain signs, as we call. So the pons in the axial show a reduction of the midline anteroposterior diameter and these two symmetrical prominences due to the impingement of the basilar artery. This was present in all the patients, as you can see here, in comparison to the normal control on the right, together with this stretching lateral compression almost of the midbrain and this abnormal shape of the brain stem. Going slightly parasagittally, you can see that the pontine artery from the basilar created this indentation of the pons in all the patient. We also found a patient that probably does not have the ACTA2 mutation, but has the severe spectrum of this brain abnormality, but without the clinical context of ACTA2 mutation. He refused the genes, but this is just to show you that the straightening of the arteries may be also due to other problems if you are not in the appropriate clinical context. If you are interested in reading about this, we try to expand the distinctive neuroimaging phenotype of ACTA2 mutation. This is the paper published a couple of years ago. What is the mechanism? Well, alpha-actin is not expressed in the brain, but also only gamma-actin is expressed. So unless we postulate a deregulation between alpha and gamma-actin, most likely the mechanism is that the abnormal straightening and rigid vessel can create a mechanical effect on the brain parenchyma. So this is not really a cortical malformation, but most likely is a deformity. So the so-called brain malformation that we think again are deformities are almost always present in the ACTA2 patients, and they involve the corpus callosum and the midbrain. Um this can help in the diagnosis, especially when you don't have an MRA available and the etiology is not clear. Thank you very much, and see you next time.